Welcome back to the Path of Longevity show, and I'm your host, Dr. Robert Lufkin, and I'm joined by my co-host, Dr. Steven Sideroff.
Before we begin, I want to take a moment to tell you about some new free online masterclasses that Steve and I are offering. For example, we know that inflammation drives all chronic diseases and aging. That's why it's called Inflammaging. But we're now learning that this inflammaging can be reversed. And one of our masterclasses will spell out the top 4 ways to reverse it. If you're interested, see the link in the show notes. And now back to this week's episode. Welcome back to another episode of the Path of Longevity podcast. Hey, Steve.
Hi there, Rob. It's good to be here with you. And I'm so happy that we have Brad Rosen here, physician who really focuses on longevity and what works, what doesn't work. So, Brad, such a pleasure to have you with us.
Oh, thank you, Steve, and thank you, Rob. Thank you both for having me and giving us all the opportunity to talk about something that I think I know from our other conversations we're all very genuinely interested in.
Yes.
Yeah, I mean, enjoyed it. You were on our podcast before in an earlier episode. We went through kind of your origin story, how you got there. But maybe we could start off today just kind of setting the stage of your approach to longevity, your philosophy of what longevity is and why we age.
Yeah, that sounds like a great place to start. So it is a field which for sure has people with many different takes. And so the take that I have is one take that I find compelling. And so for me, I started off advising a small number of people who were well off and interested in longevity and had really put a lot of resources into pursuing their own path. And basically, I started to see that most of the things that made me most comfortable and that seemed to offer the highest likelihood of benefit and were the safest were also within the financial reach of most people. You didn't need to be spending, thousands and thousands or hundreds of thousands of dollars to reap a lot of the benefits that are currently available. So I basically decided that I would take the practice pattern that I have and open it to whoever sort of felt drawn to it. And really, it is focused on, first of all, looking at the data that's out there, which is easier said than done. And you can take 10 skilled people and look at the same data and have more than one opinion about what that data is saying. And I acknowledge that. But how are we going to optimize a person's lifestyle factors, their nutrition, their exercise patterns, and other aspects of their lifestyle that could impact their health, including their behaviors and decision-making? And I think something Steve speaks well to is their mental state, their purpose, and also their capacity to shift from a pessimistic to an optimistic frame or a positive frame. And we'll call it those intangible aspects. And then the next is to optimize a person's medical metrics. We're fighting when we fight time or decay, we're partly fighting something that we don't know how to deal with, but we're also, gifted with this information that, heart disease, cancer, neurodegeneration, dementias are probably the things that are most likely to impact us adversely as we age. Ultimately, that's what age is bringing us. So from a medical perspective, some of the parameters there are beyond our control. And some of the parameters, when you look at the data, for example, systolic blood pressure, people start losing years of life when systolic blood pressure is far below what we as physicians are classically defining as hypertension. So if you're seeing a physician and you want to know if you have hypertension or not, and you're labeled non-hypertensive or hypertensive, that is sort of very reasonable standard practice, and it's evidence-based, and it's sort of the traditional model. But if you're a longevity, if you caught that bug and you're really saying, how do I maximize my health span? The data point that's most interesting to you is, on average, at what level do I keep my systolic blood pressure so that it doesn't exceed the level where I start to leave time on the table? And there's other metrics as well besides blood pressure. I know that from listening to some of your previous talks and communicating with you, you're super aware of how important insulin resistance is, and how that tends to creep up as we age. And I'm also very aggressive on that front. I think managing lipids and keeping your cardiovascular risk down is good for dementia prevention as well as cardiovascular health. And so that's sort of what I would consider to be an optimizing. You are a person who sees your doctor. You may have a more sort of toe forward rather than heel back approach to your health, and you want to have tighter parameters. It can be frustrating sometimes when you're dealing with your well-intentioned, highly competent personal physician whose paradigm is just a little bit different and it doesn't match yours. So, what I'm trying to provide is a relationship with the patient who wants to optimize these other factors. And of course, also what brings most patients in this direction is an interest in some of these longevity meds. So the last component is to talk about things like rapamycin, acarbose, some of the senolytics for people who are interested, metformin, and the like. So ultimately it's a balance. And what I think the goal is to provide people with an achievable paradigm that's consistent with their own beliefs and lifestyle preferences, that optimizes their chances for not prematurely losing their own vitality.
I love your perspective, and you're making some very good points. And in particular, the notion that the range that in general physicians say is acceptable, from your perspective, well, maybe, but if you want to live a longer life, then that range needs to be adjusted. And you mentioned systolic blood pressure. Can we just focus in on that for a moment and kind of make the distinction between what generally is regarded as an okay range and what you think is the optimal range? And again, you're referring to it in terms of longevity. I would refer to it in terms of just optimal health.
Correct. Yeah, 100%, Steve. I mean, one day, longevity is going to be about helping people fight aging directly with what we would look at today as magic drugs that treat aging. But at the current time, really what we're trying to help people achieve, and what I personally would like to achieve, and I assume all three of us would, is, how long can we live with all of our faculties, all of our strengths, all of our abilities? And the best way to do that is to avoid taking a hit. And that's one of the reasons why I take rapamycin, is because my best, the highest probability belief is that ultimately it's going to extend my disease-free time. So with respect to hypertension, it's a great example. clearly nature doesn't read the textbooks, and the policy decisions that get made that says this is hypertension and this is not hypertension are, I think, an approximation of some true value that's out there. The literature is pretty clear when you start seeing excess mortality or excess cardiovascular morbidity associated with the systolic blood pressure, that starts to meaningfully track down somewhere below 120 millimeters of mercury. And so when I was younger, and I think when we grew up, or when we all came through medical school, I think 140 over 90 was what we were taught to, recognize as, okay, identify this as a hypertensive patient. But that number has been trending down. The policy has been for lower numbers. And right now, I think 130 maybe, a number that a lot of clinicians are starting to, actively target. But when you enter numbers into regression analysis or actuarial calculators for life expectancy, you'll see once you cut over 120, you're going to start seeing big jumps in the probability of having cardiovascular disease. And when you look at graphs that chart survival and hypertension, you can see that morbidity and mortalities it's not a flat curve prior to that number. So I think that generally lower systolic blood pressure as we age is going to be a target that's worth achieving. And it's one of the areas that lifestyle really can have a big impact on. So that's always a first measure. But when you have patients coming in and say, hey, I'd like to have a extension of my health span, and you see that they're, untreated at 130 over 90. Many of these patients are not identified in their own regular care as having hypertension. And technically that may not be hypertension, although the 90 is probably borderline. But if they're interested in health span extension, they should give some serious thought to getting that number lower.
When you treat hypertension, you mentioned, interestingly, that hypertension in so many patients does respond to lifestyle, particularly low carbohydrate diet, ketogenic diet. What is your approach to treating it? Do you immediately drop it with drugs and then put them on the diet, or do you do the diet, or is it mainly just with drug control?
So the first option, assuming that we're talking about reasonable blood pressure, the kind of blood pressure levels that I think well-informed and physicians might even argue about, it's always going to be lifestyle first. The best tool that any of us have is a healthy lifestyle, period. And if hypertension, a little bit of hypertension or some slight elevation in one of your metrics is going to lead you or inspire you to adopt healthier patterns, it could end up being a net benefit for you, especially if you're able to adopt the pattern and reduce the blood pressure. But it's always lifestyle changes first, primarily, as you mentioned, with the diet. I'm also a fan of the DASH style diet, which can be done keto, no keto, but it definitely identifies, dietary aspects that affect the blood pressure, and it's a very robustly validated tool. It's not the only tool, but I think both of us, all three of us, have lived experience where we see patients adopt change and you get, remarkable improvements in their metrics. So yeah, diet first. And if I don't have to use medication for blood pressure, that's always the best preference, because I think most of the data on that topic really is saying that it's best to control your blood pressure if you can without a medication.
Yeah, And I think Steve and I both appreciate your background in traditional medicine and sort of bringing a critical view to some of these longevity approaches. You've talked before about, at first do no harm in looking at the longevity strategies. And we've talked about rapamycin A carbos before, and I want to touch on those again later. But before we do that, what's your take on stem cells? I mean, there's a lot of people doing that for longevity, and a lot of enthusiasm from certain quarters from them. Yes.
Yeah.
So, yeah, what's your philosophy on stem cells?
So it's a great question. It's a question that comes up fairly frequently. I think that the promise with stem cells is enormous. I think that the regenerative medicine space is extremely exciting and promising. I think it is going to be a huge part of the future. I think also that most people right now have expectations for the benefits of stem cells that are probably exceeding what the stem cells can currently deliver, and that some of the risks of stem cells are either not as well defined as I would like before I lightly suggest that a person go for stem cell therapy. And some of the risks are known, but not particularly widely known. For example, having, ectopic deposition of a stem cell. I get a stem cell infusion. Some small number of these stem cells land elsewhere. They set up shop, they grow. And years later, I have a tumor, not necessarily a malignant tumor, but it's derived from this injection. This isn't something that's common, but it's something that's significant enough where, for me, if I have an unquantified upside and I know that there's certain downsides, that's is not something that's trivial. I wouldn't want to have, for example, a benign tumor on a vital organ, or I wouldn't want to have on a vocal cord or some area where my function's affected. And then there's also concern about the stemness of stem cells. And the close link between stemness and malignancy. So I am somebody who is following the space. I'm excited about it. I'd love to think that I may one day benefit from stem cells, and maybe we all benefit from stem cells one day. I'm not sure that it's totally ready for prime time for most people at this point.
And sort of a follow-up to that, maybe not quite as aggressive or on the edge or over the edge of stem cells. You mentioned senolytics before. Could you explain what those drugs are, and then your approach to them, and what role you think they play in a longevity strategy today?
Sure. So the accumulation of senescent stem cells is one of the proposed mechanisms through which aging results in loss of function. And you end up with these senescent cells that are increased in their prevalence in the tissue. They not only don't function very well, but they produce this, SASP, which is senescence associated secretory protein, which contains pro-inflammatory, we'll just call them elements. And when you remove the senescent cells from tissue, the tissue appears to behave as if it's younger. And when you add senescent cells to youngish tissue, the tissue behaves older. So there's a good foundation of basic research suggesting that removing these senescent cells can be beneficial. So the question is, what agents can you use that effectively do that in humans and can give a outcome-based result? So dasatinib is probably the most well-known and accepted at the moment. And then given in combination with either quercetin or fisetin, I think this is what most people would consider the most commonly accepted senolytic cocktail. So dasatinib doesn't when you administer that to a person, there's a good chance they're not going to enjoy the experience. There's some flu-like symptoms that can go along with that. It is a pretty non-specific drug. It's a tyrosine kinase inhibitor, and that's a ubiquitous tyrosine kinases are everywhere. So for me, there are patients who are very much ready to dial in for themselves a senolytic therapy. So I'm more than willing to supervise those patients and prescribe the cocktail, but it's not first line. It's not something that I would recommend for everybody, mainly because outcomes still are, I would say scanty, right? Finding great human data is not easy to see. And then the side effect profile is also not as favorable. When people take rapamycin, they don't usually have adverse side effects. The main one is sometimes disappointment that I don't feel younger immediately. But that's one I can tolerate, and we can work around. So, but I think that in the future, senolytics is also something that is, it's inspiring. It is a approach that really makes a lot of sense. And I'm looking forward to us having really targeted senolytics that do exactly what we want them to do. And we have good evidence to show that that's happening.
Mm-hmm. Cool, cool. A lot of clients that I see are worried about their own neurodegenerative processes as they get older, and or they're dealing with those kinds of conditions already setting in their parents and that generation. What do you suggest for neuroprotective treatment or supplements or approaches?
Okay, this is another very common concern, and 100% neurodegeneration is something we have to look at as people who are protecting health span. That's something that we want to push off or prevent altogether. I think when Rob was at what was the meeting you were at in Las Vegas recently?
A4M. Steve was there too. We were both.
Oh, you guys were there together.
Yeah,
okay, great. So I was at a meeting in the Bay Area at that time, and there was this great poster that I saw looking at using machine learning to detect motion abnormalities that predicted neurodegenerative changes in the future in an animal model. So they were using cameras to look at movement, and they broke that down into movement syllables, but basic movements, and saw that these movement constrictions predicted neurodegeneration in the future. And I think that's super interesting because I would say that if I were to pick a single intervention, it would be exercise, making sure that you're budgeting sufficient time in a week for your own movement, for your own aerobic fitness, and for your own resistance training, that an observer would say that you have a robust exercise program in place. I think that the data for that is would put that at in my top spot. I think that you can look at some of the recommendations that various dementia clinics around the country. I think there's one big one in Cornell. There's another one at FAU. Where people who maybe have an ApoE4 or have a family member with dementia, they'll go and they'll say, how do I prevent dementia? It's a great question. So there's particular diet recommendations. There's a MIND diet, a MIND diet that has been validated. I think there's been 3 separate researchers who looked at that and marked adherence to that diet with a reduction in the progression of cognitive impairment in people with cognitive impairment from age-related dementia. And I think that's something just hard to overlook. I mean, if somebody were to say, here, I have this drug that might reverse your cognitive impairment, it would be a blockbuster. And so the MIND diet and related diets are something that I would refer patients to or endorse. I know that in some instances, keto changes can be super helpful for people who have had some types of neurodegenerative illnesses. I think in particular, Parkinson's and keto esters have a history of working closely together, but primarily MIND diet recommendations and in that direction. I think that DHA supplementation makes sense. I think looking at your omega-3s, your omega levels, omega-6, omega-3s in your blood, and seeing where you are with, for example, homocysteine. There's a lot of people who have a particular genetic deficiency where maybe their homocysteine is elevated, and those people can take methylated B vitamins and have improvements that might be meaningful for them. And the other thing is that LDL or ApoB, depending on which flavor of word you prefer, LDL-C lowering seems to be associated with protection, meaning if you have elevated LDL-C or ApoB, your risk for developing dementia is elevated, which in some regard makes sense because a third of dementias are not necessarily genetic or predetermined, they're vascular. So keeping your vascular system healthy makes a lot of sense as well.
One of the most popular supplements that we hear about or strategies, longevity strategies, is the use of NAD precursors. What's your view on those, Brad?
So a lot of people will be asking about the NAD precursors, whether it's NMN or NR or the basic B vitamin to keep their NAD levels elevated. There's a lot of other resources out there that have active conversations about the NAD plus system. As a longevity drug, I'm not entirely bowled over by the evidence that I see. I think that there's some other health metrics that you can show with NAD plus supplementation. I think for younger people, the logic, even though the outcome data is missing, there's still a logic. And so I see a lot of younger patients who are taking the supplements, but they're taking it at a time in their life where their NAD levels haven't quite dropped yet. So that's the one area where I would say that is a big question mark for me. There's also some good evidence that non-alcoholic fatty liver disease is a good target for NMN or NR therapy. And for some women in particular, polycystic ovary syndrome can respond to NAD supplementation or NMN, NR. So those are two places where I might recommend it specifically, but it's not something that I don't tell a person if they're taking it to stop it's bad, but I don't tell a person who's not taking it that they have to and must be and should be, and they're missing out if they're not.
So one of the conversations that Rob and I have quite a bit of is you can take a supplement, and let's stick with NAD, for example. The question is the body fully utilizing it, or is it just getting passed out in your urine? Now, do we know about the effectiveness of taking, say, NAD supplement?
It's a great question. I think absolutely some of it doesn't get absorbed. And so I think that the bioavailability of most supplements is not going to be 100%. I mean, it's literally the $1 billion question. How can you create a supplement that is A, bioavailable, and B, getting to its target, and C, having the effect that you hope it's having, and D, not having some other effect, either a bad effect or neutralizing the effects of something else that you're taking that is giving you benefit. I don't really feel that I have a great answer there.
Okay. In your practice, given the importance of this, how do you address stress and psychological factors as part of an overall longevity plan? What's your thinking on that?
So my thinking on it and how I address it are definitely not 100% overlapping. I would defer to Steve here. It is something that I feel very strongly about. It's something that I read extensively on, but not every patient who comes in wants to necessarily open up that hatch and explore that space. And I'm not a trained mental health specialist, and it's easy to underestimate how powerful that whole space can be, and how hard this can be for some people. I mean, that whole story about all the people living lives of quiet desperation. We don't know. People can be so well put together, and when you realize, if they're willing to share, how much they have put up with over how much they've experienced, how much they've endured to get where they are, and to put themselves together and show up day after day. You want to give people, if you could, be a spirit giving hugs out to people and acknowledging them and seeing them, and even going back and acknowledging the child that they were. It would truly be transformative, I think. I believe that the early adverse life experiences that a person has marks them in ways that they're not aware of unless they do a lot of digging and self-observation and work to see the patterns that ensued. And it's clear that adverse childhood experiences impact mental and physical health for life. And it's not a magic process. There's behaviors that occur, whether they're addictive or compulsive. People that say, I just can't stop myself when I get fill in the blank from eating these sweets to excess. I mean, maybe there's something that if they were able to understand where that compulsion's coming from, which is usually in the space that you're asking about, they're able to unlock some behavioral changes that otherwise are just, they're in a loop because they're powerless to change those things. So I will ask almost every patient about are they aware of the role of adverse childhood experiences on health? And if not, then I suggest that they just become familiar with it. I don't want to pry too much, but I want people to be aware so that they can start a journey if it needs to happen. Or if they have started that journey, to acknowledge it. I try to encourage people to maintain a gratitude journal. I try to encourage people and to understand the importance of positive affect, gratitude, optimism on physical health metrics. It's a real thing. In a perfect world, I think that along with the time people dedicate to working out, a sort of dedicated period of time to cultivating the better aspects of mental health is so worth it, but hardly anybody does it.
Mm-hmm. Yeah, so I completely, of course, agree about the importance of the psychological, the mind, on the body. In my experience, autonomic dysregulation resulting from stress, resulting from emotional reactivity, drives a lot of chronic illness. And so there's a direct interplay there.
Yeah, no, 100%. I mean, you wrote the book on it in a sense. So I think it is a sort of, it's very personal, but it is impossible to overstate how important it is. And, ultimately, if a person wants to have a long, healthy life, if they are lacking an understanding or a sense of self-purpose that motivates them and drives them to understand why that long, healthy life is going to be of value to them, to the people they love, or to the world at large, or is not going to be generally a pleasurable experience, in the not necessarily in the hedonistic way, but spiritual way, then it's very hard. It takes work to do this. I mean, you could get lucky, but if you're going to embark on a health span journey, it takes dedication, it takes discipline, it takes some work. So that component it's like having no wind in your sails if you're missing it.
Right. Well, it's always a fascinating conversation when we get together, Brad. We appreciate this, and we hope to have you on again and continue this conversation.
No, I think there's a lot of topics to discuss. I would be always delighted to come back and even identify something in advance that we want to go on a deep dive with. But thank you both so much.
That would be great, Brad. I appreciate it. And just to let our audience know, you do have a practice, and you have a telemedicine practice also. So you can accept patients they don't have to be in Los Angeles where you're located. And maybe you could share that with our audience. We'll put it in the show notes as well, but just share how they can follow you on social media or your website also.
Sure. Yeah, no, I have a Twitter account, modestly active. It's Bradley S. Rosen, MD. My website is mtormedicine.com. And my email is mtormedicine@gmail.com. I think any of those are good ways to either reach me or read my website. Yeah.
Great.
Always happy to see patients and always happy to take questions.
Great. Wonderful. Well, thanks again, Brad, and we'll look forward to the next time.
All right. Thank you, guys. Thank you both so much.
Yeah, thanks, Brad. It was great.
This is for general information and educational purposes only, and it's not intended to constitute or substitute for medical advice or counseling, the practice of medicine, or the provision of healthcare, diagnosis, or treatment, or the creation of a physician-patient or clinical relationship. The use of this information is at their own user's risk. If you find this to be on the value, please hit that like button to subscribe to support the work that we do on this channel. And we take your suggestions and advice very seriously, so please let us know what you'd like to see on this channel. Thanks for watching, and we hope to see you next time.